Hi, this video focuses on the diagnostic shoulder arthroscopy. We'll review the pertinent anatomy of the shoulder. We will discuss some of the common portals used during a diagnostic arthroscopy. And with the help of some intraoperative pictures, we will try to review how to perform a diagnostic shoulder scope. Once the patient is prepped and draped, one should always begin by identifying all the palpable anatomy. Some of the bony landmarks that should be identified are the acromion, the clavicle, the coracoacromial joint, scapular spine, the coracoid, and mark out any portals that you wish will be necessary throughout the surgery. Identifying all these structures are important for a safe and accurate placement of your portals. Portal placement is the same for both the lateral decubitus and the beach chair positions. Some of the common portals are illustrated here in this drawing. Most commonly, the anterior and posterior portals are used. The posterior portal is the first and safest portal to prepare. A standard posterior portal is a typical starting portal for access to the glenohumeral joint and subacromial space. It is usually used as your main viewing portal throughout your procedure. You can palpate a soft spot in the posterior glenohumeral joint that can be palpated to ensure appropriate placement. You can measure this for a guesstimate to be 2 to 3 centimeters inferior and 1 to 2 centimeters medial to the posterior lateral aspect of the acromion. The higher you place your portal, the more facility you will have in repairing a cuff, while a lower position portal appears to be better for labral repairs. When you're entering the joint, you should always aim towards a coracoid. Once in the joint, an anterior portal can be established. This can be accomplished based on surgeon preference, either outside in with a spinal needle or inside out with a switching stick. This portal is mainly used as a working portal. However, you can use it as a viewing portal as well. Needless to say, care must be taken to stay lateral to the coracoid process in order to avoid the brachial plexus and the axillary vessels. The musculocutaneous nerve is reported to be approximately 30-35 millimeter inferior to the tip of the coracoid. The lateral portal can be established with a spinal needle for localization, typically in line with the posterior border of the clavicle and 2 centimeters lateral to the lateral border of the acromion. This portal is typically used to address acromioclavicular joint pathology and for subacromial impingement. Moving on with the diagnostic arthroscopy, I'll try to illustrate with the best of my means through pictures in these following slides how to perform a diagnostic scope, but for anybody who's interested, YouTube has great videos. The usual sequence while performing a diagnostic scope is as follows. Once you have established your posterior portal, you should first visualize the rotator interval. This should be a landmark that is first visualized before undertaking a diagnostic scope. At this point, many will create an anterior working portal so they can use a probe throughout the diagnostic scope. You first use the probe to assess the integrity of the bicep tendon. You can also assess for any slap tears on the superior aspect of the labrum. Then you should follow the tendon to where it exits the joint. Bringing the scope anteriorly, just inferior to the biceps tendon, you will be able to assess the anterior pulley and the superior edge of the subscapularis. By rotating your scope laterally, you will be able to appreciate the undersurface of the rotator cuff and the insertion of the supraspinatus muscle onto the humerus. These are identified in the picture. As you bring the scope more posteriorly, and by looking inferiorly, you'll be able to see a small bare area, which is normal, as well as the attachment of the infraspinatus and teres minor. The scope is then dropped into the inferior recess. By externally rotating the arm, you will be able to appreciate the posterior inferior glenohumeral ligament. Often, should there be loose bodies, this is where you will find them. Finally, by taking the scope upwards, you will be able to visualize the posterior labrum and then assess the integrity of the joint cartilage of both the glenoid and the humerus.